Thank you, Mr. Chairman. I appreciate the topic of our hearing today. I'm hearing a lot of contradictory claims and concerns and maybe conclusions. I want to direct a couple questions to Dr. Hunt, who I don't think has had opportunity to participate today on question and answer. But based on the tenor of a relatively recent presentation you gave called A Model for Providing Services for Returning Combat Veterans, it's apparent that you and others in the VA believe Gulf War illness is a mental disorder. Is that correct?
That is not correct. I'm not sure where you got that information.
Did you not have a presentation entitled A Model for Providing Services for Returning Gulf War Veterans?
Presented where?
I don't have the place of presentation.
I don't believe that, and I have never said that, and I do, no.
Oh, so this wasn't your presentation, Matt?
It could be. I would have to look at it. I'm not sure.
Okay, well, I don't know. You never made a presentation on a model providing services for returning Gulf War veterans?
I give presentations on that often. But I would like to see it because it certainly is a misinterpretation of what I believe, and I suspect what I said.
So do you believe also or otherwise that psychiatric drugs are the best treatment for veterans with Gulf War illness?
I believe that medications should be used for conditions they're indicated for, and psychiatric medications are not indicated for Gulf War illness.
So what kind of treatments would you suggest then?
I think 25 years ago, what was going on with me was I was starting to see people coming back in 92 and 93, coming back from the war. And the things that they were saying when they came back were not, I have Gulf syndrome or I have a mystery illness. What they were saying was, I'm not doing very well. I'm having a lot of trouble. Having trouble at home, work's not going well, can't do my PT for my reserves, Guard and Reserves, and so on. And our response to that was to set up a clinic for returning combat veterans that really was looking at the various ways that the deployment impacted their health, how it impacted their health physically, how it impacted their health psychologically, emotionally, spiritually, how it affected their families, and we came up with a model of integrated care to support Gulf War veterans. It became the Gulf War Veterans Clinic. That eventually morphed into what we called in the VA deployment health clinics, or turned into what we call the Post-Deployment Integrated Care Initiative. I have never, the first veterans as I came back, I would not have said this is in your head or I think this is a mental condition. I would have said, you're having trouble. I don't know exactly what all is going on, but I know you've been off to war. I know you've been exposed to a lot of things. I know you've had some very difficult experiences, and let's see what we can do to get you back on your feet. I've had an eye on two things. One is the sort of research that Dr. Gollum and Roberta and Lee Steele have been doing to try to figure out what's the cause of this Gulf War illness that's very discrete. Clearly, we have higher rates of these symptoms and this problem in Gulf War veterans than any other cohort I've ever seen. The research is important. At the same time, we had to have a way of helping people. And so our clinical focus has been, how can we help you get back on your feet by providing you with good integrated care that includes symptom management, that includes medications when they're appropriate, that includes...
Are the psychiatric drugs most effective, you believe, or what have you seen in...
I think the most effective thing is good health care, is appropriate evaluations and treatments for diagnosable conditions, getting people resources they need through service connection. This is the first time we've given service connection.
Excuse me, sir. I mean, that's general. I'm asking about psychiatric drugs. Are they effective in the treatment or not?
They're effective in the treatment for indicated conditions. If a person, one of the problems we had, and Anthony, I was thinking about this when you were talking as well, because of the suicide issue, if we see Gulf War veterans that have unexplained symptoms or Gulf War illness, they may also have concurrent or co-occurring depression, and they are at risk for suicide. And so it's very important that we don't look at this as either or. And if a person has a mental health condition, that they get appropriate treatment. Which
my concern is it seems like the psychiatric drug approach seems to be where the simplest choice for the VA to make.
I would not say that.
And I appreciate you disagreeing with that. Last thing, I want to ask a question of Dr. Cory Slechta. In your recommendations, you do suggest no further studies should be undertaken on cause and effect relationship because you don't have definitive and verifiable individual veteran exposure information. Is that correct? Is that your recommendation?
There were no measures made of internal exposures of veterans, and there were no measures made even of environmental exposure levels. This is basic principles of toxicology and pharmacology.
So in your opinion then, and I understand that, in your opinion then, all the previous studies that attempted to determine that, are they invalid then?
I don't think you can rely on self-report, because there will be people who were actually exposed who don't even know it.
This is not about self-reporting, it's whether you have definitive or verifiable individual veteran
I think
exposure.
it's possible to get those kinds of measures, and that's what I stressed before, that in the future, we need biomonitoring devices and GPS tracking devices so we can, in fact, get that kind of information and make those associations.
Okay, and I understand that. I was just trying to figure out whether you thought we had that in the past, and to me, that calls into question a number of these studies if we don't have that type of information. Lastly, you do request additional studies of sex-specific and race and ethnicity-specific health conditions. If we don't have the individual exposure information, how do we determine?
Well, there may be, we know a lot of diseases and disorders differ in their manifestations by sex or by race, ethnicity.
If we don't have the exposure information, which is the key
I
variable,
think
how do you
it's a
study
different
that?
point. It's a different point. The exposure information, what this committee has said is that we'll never be able to understand how those exposures actually related to these health outcomes. We don't have any objective
We
exposure.
don't know whether they have exposure or not, is your point.
Sorry?
We don't know whether they have exposure or not, is that the claim?
We know there were exposures. What we don't have is actual information for individuals that we could look at it in relation to health outcomes.
Well, I
We
understand.
know there were
So-
exposures. yeah.
So I don't know how you do your second round of studies that you've recommended. You say abandon the first round, but the second round you're talking about race and sex.
We're just saying for any health outcomes, because oftentimes for many different diseases and disorders, their manifestations and sometimes their mechanisms differ by sex and by race, ethnicity. In order to really understand and or treat them, you may be doing it very differently. Heart attack is very different in a man and a woman, for example. So we need to break those out and look at them.
Thank you, Mr. Chairman. I just found it concerning that the basic exposure information is, we're hearing that, well, we don't know what it is. And so if you take that variable out, I mean, that strikes out a lot of information, a lot of data, and a lot of research would be thrown out by the Institute of Medicine. And we spend a lot of time, attention, and money trying to figure this out. So very concerning. I yield back.